Welcome back, everybody. Hope you had a nice little rest break. And we're back for the second part. I just wanted to apologize if there was a little bit of background noise there. I've discovered what it was. A couple of people have the link, some of our clinicians, and they might be linking on my link. And just to make sure they realize to make sure they're mute on their phone or computer, what they're using, because otherwise we might hear a little bit of background noise. It hasn't been disruptive, so but just obviously it'd be embarrassing or it would put our speakers off. So thanks very much for that. I'm delighted to welcome my colleague, Dr. Aoife Twohig. Aoife was formerly a colleague working with me in Children's Health Ireland, Crumlin, as a liaison consultant psychiatrist. And now sadly we have lost Aoife over to Temple Street, but it's Temple Street's benefit where she continues to work in liaison psychiatry. When Aoife was in Crumlin, she was clinical director of St. Louise's unit. And obviously, for those of you that don't know, that's a service for the assessment and treatment of young people who have experienced child sexual abuse, a very important service, a much needed service in Ireland. Prior to Aoife's clinical work as a consultant and her role in that, Aoife has always been interested in early attachment and infant mental health, has worked both clinically and academically in that area, and in fact has gained expertise and clinical skills in psychotherapy and is a child psychotherapist. Aoife has also done her PhD in the area of attachment and infant mental health. So Aoife, thank you so much for giving up your evening from Temple Street and looking forward to your presentation.
Thanks so much, Fiona, and thank you for everyone who's attending. I'm just going to share my screen and also and thank you to sorry, now I'm just going to get onto the right slide. And thank you to the previous speakers as well. They were very interesting presentations. So thank you for the introduction, Fiona. So when I was preparing for this presentation, I reflected on the much acclaimed film on Colleen Kuhn, which is wonderful to see. It's been nominated for the Best International Film in the Oscars. And I just might begin my presentation just reflecting on some of the themes that are presented in the film, because my topic tonight is about childhood trauma. In this moving Irish language film based on Foster, the 2010 novella by Claire Keegan, a young girl is brought to live with her relatives she does not know while her mother awaits the birth of another child. The story and film sensitively depict the young narrator's experiences of a home life lacking in affection and attentiveness before she is sent away, and her tentative and then describes her tentative developing relationship with her foster carers, both of whom are responding to her in different ways in light of untold sadness and what Selma Freyberg termed ghosts in their nursery. I was struck when I watched the film recently of the sparse yet simple dialogue, Os Gaeilge, and the slow-moving yet sensory-rich scenes, which evoked in me memories of my own childhood, of life in rural Ireland, but also the idea of fragmentation of memory and sensory processing associated with the experiences of severe stress, loss, and trauma. One reviewer of the book spoke of its description of the painful experience of unaccustomed love and tenderness that can be because they accentuate what has been lacking. And there's a quote from the book that I just want to read out. Walking to the beach, Mr. Kinsella, who is one of the foster carers, thoughtfully adjusts his strides to the child's and takes her hand. The narrator notes, my father has never once held my hand, and some part of me wants Kinsella to let me go so I won't have to feel this. And then she adds, it's a hard feeling, but as we walk along, I begin to settle and let the difference between my life at home and the one I have here be. The young narrator, a victim of neglect rather than abuse, captures how particularly hard the ensuing guilt and other complex reactions can be on children, torn between attachment figures. So in my talk, I just want to talk a little bit about the historical context of childhood trauma. I was also talk about some definitions of childhood trauma and child abuse. I'll talk about the prevalence currently in Ireland and across the globe. Also I'll talk about assessment and diagnosis within clinical settings, and also the therapeutic approaches that we use in our work. At the hospital of the Salpêtrière in Paris, Jean-Martin Charcot in 1887 first proposed that the symptoms of what was then called hysterical patients had their origins in histories of trauma. Charcot's student Pierre Janet described 591 patients, 257 of whom had a traumatic origin of their psychopathology. Janet described how the memories of these traumas tended to return not as stories of what had happened. They were reenacted in the form of intense emotional reactions, aggressive behavior, physical pain, and bodily states that could all be understood as the return of elements of the traumatic experience. Janet proposed that the efforts to keep the fragmented traumatic memories out of conscious awareness eroded the psychological energy of these patients. This in turn interfered with the capacity to engage in focused action and to learn from experience. Unless the dissociated elements of the trauma were integrated into personal consciousness, the patient was likely to experience a slow decline in personal and occupational functioning. And in Freud and Breuer's work, subsequent to the work of Janet, they described the memory of the trauma acts like a foreign body, which long after its entry must be regarded as an agent that is still at work. So I suppose when we're thinking about childhood trauma, we do need to think about the physical, sexual, and emotional abuse and neglect of children, which are which are associated with substantially increased risk for concurrent and subsequent psychopathology. These are unfortunately common problems encountered by clinicians working in child and adolescent mental health, in primary care, in a range of health and social professions, and indeed in schools and across all sectors of society. We also have to take into account that there are complex family and systems forces surrounding children and families who experience abuse and trauma, and these lend to the complexity of assessment and treatment. Assessing maltreated children requires more time than children who have not experienced maltreatment. And this needs to, we need to be able to take the time to ensure that appropriate assessment and comprehensive assessment of multiple factors is conducted. Young children, especially who experience the highest rates of maltreatment, are particularly in complex assessment, and partly this is due to their high sense of dependency upon their caregiving environments. A traumatic event can be a recent single traumatic event, like a car crash or a violent assault, a single traumatic event that occurred in the past, a sexual assault, the death of a parent, spouse, or child, or an accident, or living through a natural disaster or war. But there can also be a long-term chronic pattern of ongoing, for example, ongoing childhood neglect, sexual or physical abuse. that causes a particular traumatic, that has particular traumatic impact. And just to define childhood maltreatment, it is any act or series of acts by a parent or caregiver that results in the potential for harm or threat of harm to a child. And that's just from the WHO. We know then that experiencing child abuse or neglect can result then in the development of a range of symptoms, and some children or adults will develop a syndrome called post-traumatic stress disorder, and that may be simple or complex. Experiencing a single traumatic event is most likely to lead to simple post-traumatic stress disorder. But complex PTSD, which I'll mention a little bit later on, which has now been defined in the ICD-11, tends to result from long-term chronic trauma and can affect a person's ability to form healthy, trusting relationships, in addition to having a wide-ranging impact on mental and physical health. Complex trauma in children is increasingly being referred to as developmental trauma, following the work of Bessel van der Kolk, which Emer had mentioned earlier. I just want to talk a little bit about the prevalence rates of child protection concerns in Ireland. And I draw on a recent TUSLA report for the first part of 2022. I just thought it would be really interesting just to look at the current statistics that we have in Ireland. I'll also draw then on some literature quoting European statistics and US rates, in addition to some global rates. I think some of this is quite stark findings. So in the second quarter, so that's a 3-month period of last year in 2022, there were 21,186 referrals to child protection and welfare services. And that was the highest number of referrals that had been submitted in the new system that TUSLA have developed for online referrals to child protection. When you included Q1 and Q2 together, there was a total of 41,079 referrals. This is for nationally in that 6-month period. And that was over 6,000 more than the same period in 2021. Just over half, so 55%, were welfare concerns. So that's where there's broader concerns about maybe the needs of the child for safety, food, housing, care that don't reach a child protection level, where the nature of the report or the referral to child protection services. But still at 36% were specifically due to concerns around abuse or neglect. And the most common referrers were An Garda Síochána, which accounted for 35%, a lesser extent by social workers, and a similar amount of teachers. And you can actually get the breakdown of all nature of referrers on the TUSLA website. And this is just a breakdown of the report type. So as you can see, just over the 50% are welfare concerns. Emotional abuse is actually the next highest, with a pretty consistent rate of about 16%. Neglect is around 5%, and physical abuse is 8 or 9%, and sexual abuse surprisingly is quite high at 6.5%, and then about 10% the reason is not recorded. So of the 35% of referrals in Q2 of the Q2, of the referrals received in Q2, 35% progressed to what is called a preliminary inquiry stage. So that's the first stage of the assessment. And 90%, almost 90% were closed at the time that the data was extracted and 11% there was ongoing assessment and safety planning happening. And 29% of those that had a preliminary inquiry required an initial assessment. And then 7% were diverted to a broader pillar of TUSLA, which isn't child protection, but provides intervention. Then after the initial assessment, 50% of those were closed. 19, so about 20% were ongoing, and 30% were still awaiting commencement. 30% required safety planning following completion of the initial assessment. 17%, so that's 160, required a child protection response, child protection case conference, which is a very high level of need, and 3% or 30 referrals or children required admission to care. So I just think they're quite stark figures in terms of a 3-month period in our nationally at the moment. In America, the CDC report has highlighted that in 2016, over 1 billion children worldwide have experienced violence in the past year. And a report in the same year estimated that approximately 676,000 children in the United States were confirmed as victims of abuse and neglect by child protection services, which is an incident in America of just under 1% of the population. But again, as can be seen from the Irish figures, there's a much greater referral rate of 3.5 million children with a concern around child protection. And we know that younger children and children from ethnic minorities are at much higher risk of maltreatment, and indeed of very serious outcomes of maltreatment. So again, these are just some more very stark facts, that more than 1 million children under 3 were the subject of abuse and neglect in 2014, and that in low and middle income countries, so in developing countries, UNICEF reported in 2015 that 7 to 8% of parents of 2 to 4-year-old children reported beating their child. And we know that children under 3 are more likely to die as a result of abuse and neglect. And 71% of fatalities, more than 1,000 children per year in the United States, die from maltreatment. Neglect, however, is the most prevalent type of maltreatment. We also know that it is actually very rare for a form of maltreatment or abuse to occur on its own, that co-occurrence is much more likely, and where a child has been exposed to maltreatment of one kind, it's likely that they've been exposed to other maltreatment. And that was very much my experience when I worked in St. Louise's unit, that we were not only working with child sexual abuse, we were working often with very complex histories of multiple adversities, multiple ACEs, transgenerational trauma, and so it's a very complex area to work in, and to try to address the needs of the most vulnerable children. And that just gives a little bit of breakdown of how few children had experienced single types of abuse in that study. But I think we have to remember that not all stressful events involve trauma, and the recent DSM-5 definition of trauma requires actual or threatened death, serious injury, or sexual violence. Stressful events not involving an immediate threat to life or physical injury, such as psychosocial stressors, are not consider trauma in this definition. 3 qualifying exposure types: direct personal exposure, witnessing of trauma to others, and indirect exposure through trauma experience of a family member or other close contacts or associates. They are the 3 exposures in the DSM-5. But just reflecting on the previous presentations, you know, we do understand trauma in many different ways, and I suppose this is probably a more clinical perspective on the nature of trauma and the impact of trauma. Without trauma exposure, then, according to the DSM-5, psychiatric symptoms would not qualify as PTSD. And just to mention, the symptom groups that are identified in the DSM-5 include intrusion, avoidance, negative alterations in cognition and mood, and alterations in arousal and reactivity. But there has been much controversy about the DSM-5 criteria due to the heterogeneity and diversity of possible presenting symptoms. So there's still a lot of debate and questioning going on. And just to draw attention, there are specific criteria for children under 6 years of age due to their developmental level. So children do not have to have the repeated extreme exposure to aversive details of the traumatic event, and indirect exposure through a close associate is limited to a parent or caregiver. And intrusive memories in younger children do not have to appear distressing, because we see in younger children reenactment through play quite frequently, and it isn't always distressing to the child, but may illustrate an attempt to master, an attempt to work through a traumatic event. And nightmares do not have to be based on the event. So ICD-11 was subsequently released in 2018, and this has approached PTSD in a different way, and tried to be more clinically, to have more clinical utility and simplicity in its diagnostic structure, and it proposes guidelines as opposed to criteria. And the heterogeneity or the variety of symptoms that survivors of trauma experience is recognized, or it attempts to recognize them. And it provides then 2 disorders: PTSD or simple PTSD and complex PTSD, which are considered then siblings under disorders specifically related to stress. I just wanted to talk then, I hope I'm okay for time, Fiona.
You've about 3 to 5 minutes maximum, Aoife.
Okay. Secure attachment, we know, and the other speakers have you know, referred to this, is protective against trauma. And I suppose speaking you know, about young children in particular, the emotional health of young children is closely tied to the social and emotional characteristics of the environments in which they live. Emotion itself is a biologically based aspect of human functioning and wired into multiple regions of the central nervous system. And this has a long history in the evolution of our species. And as the baby's brain grows and connects, as we've seen in utero and in the postnatal period in the first years of life, these interconnections in a secure and responsive and sensitive environment support the emergence of mature emotional behavior, particularly in the preschool years. And so it's felt that this experience of sensitive caregiving in the early years is in fact protective against trauma and subsequent trauma during life. So as young children develop, their early emotional experiences become embedded in the architecture of the brains. And we've seen with the other speakers as well, the experiences of newborns and young infants their emotional development occurs during interactions with their caregiver, such as feeding, comforting, and holding. And when care is sensitive and responsive, this promotes emotional regulation and processing of experiences. But when feelings are not well managed, thinking can be impaired. So we see when a child finds it hard to regulate their emotions or is under chronic stress and distress, perhaps through a challenging home environment and what they're exposed to in the home environment, the circuits that are involved in emotional regulation actually are not becoming formed in a way that enhances their thinking and executive functioning skills and their capacity later in older childhood to problem solve. And they function in that more emotionally vulnerable and primitive state, and with a hyperactivity of the cortisol system as well. So here we have quite a complex neural diagram of the brain and the pathways that are involved. And I won't go into this in too much detail. It's been mentioned previously, but we know that there is dysregulation of the norepinephrine and cortisol systems, and stress and this dysregulation affects the development of vulnerable areas of the hippocampus, the amygdala, and the medial prefrontal cortex, which are felt to be associated with the symptoms of trauma. So just in terms of the impact then in childhood, we have to remember there can be acute physical injury involved in all kinds of abuse, and that medical assessment and needs to be considered. So we would have worked quite closely with the pediatricians and nursing staff in St. Louise's in Crumlin to ensure that any physical injury, whether it is to the genital area, whether it is to other areas of the body, can be assessed in a sensitive way. And there's a really nice model now being developed. It was in development when I worked there, but since I have left, where there is an integration of the medical, psychological, and social aspects of care of the child. And we call that a Barnahouse model or a one house model, where now children can have their medical needs and need for treatment and assessment of any physical injury done in a way that is holistically integrated to the psychological and the social needs following trauma, and the importance of supporting family and parents at that early stage as well. We know that medium to long term, then there's the impact, the psychological impact, such as anxiety, depression, PTSD, complex PTSD, or developmental trauma. But there's also a whole range of other mental and physical symptoms and disorders, and quite prevalent among the population that I would have worked closely with would have been eating disorders, attachment difficulties, some attachment disorders, and disorganization, as well as some children presenting with symptoms of OCD, some children presenting with psychotic-like disturbances. So the whole range of psychiatric needs are prevalent. And we can just see here some of the statistics that 48% of the population in a study had clinically significant emotional or behavioral problems. These are American studies. And that children recruited from a pediatric center who had been maltreated were 3 times more likely to be diagnosed with internalizing or externalizing disorder. And about 45% of childhood psychiatric disorders are reckoned to have been the result of previous adversity, including abuse and neglect. And so we have to think about the experience of trauma and adversity when we're working with our young clients in our clinics. I've kind of outlined, I suppose, a lot already about the importance of the early years. And I suppose really just to summarize that, the next few slides, it's just that sometimes there's a sense that very young children, I think we're getting much better at this, but sometimes there's a sense that very young children are not, do not suffer from mental distress or disorders. We're good at recognizing difficulties in the care of infants, but young infants and young children actually express about the same prevalence of disorders, psychiatric disorders as children across the whole range of childhood. But our clinical services for very young children are sadly very underdeveloped. Our CAM services are also very underdeveloped, but infant services are much less developed.
Wrapping up, Aoife, yeah.
I think I'll just skip on to, obviously we've talked a little bit as well about the wide range of presentations in the school-age child, in particular peer relationship difficulties, cognitive and attentional difficulties. And we know as well that children with neurodevelopmental difficulties and learning difficulties are particularly vulnerable. And I just want to mention with adolescents, again, we're seeing increasing rates among adolescents who have been victims of serious sexual assault, victims of serious physical assault, and witnessed serious violence. We're seeing increasing peer-to-peer violence among both male and female, young people. We're seeing an exponential rise in online grooming and abuse, bullying, and also substance use. Again, there's a lot of advances in terms of assessment. We're very lucky in St. Louise's and St. Clair's and in other services around the country to have highly skilled professionals working therapeutically with young people, but we need more of these services, and we need to recognize the level and the prevalence of abuse and trauma, and appropriately develop services for children and families. I think that's all I'm going to do, Fiona, and just to know the trauma-informed care as well is really important.
Well, maybe, Aoife, in the panel discussion at the end, you might be able to cover some of those points. I mean, I think your talk was very interesting and very informative, alarming in terms of the statistics you presented, but maybe we will get a chance to come back to them. So thank you very much. It's lovely to see questions are coming in.